So hello everyone, let's take our next question. So our next question is: a patient reports experiencing flank pain with a hematuria. X-ray reveals there is a presence of multiple calcifications. Query: stones in the both kidney. Now what is the most probable diagnosis in this patient? Now your options are a parathyroid adenoma, option B, renal calculi, option C, polycystic kidney disease, and the option D, that is your CKD. Right? Now let's try to understand how a patient with renal calculi will present it to you. So obviously, look, there is a stone that has been stuck in the ureter or the urinary tract system, right? Sometimes it may be stuck in the renal pelvis as well. Now, as a result of that, there is a cramp like spasmodic pain that has been noted in such cases. Now, this pain is eventually situated initially at the flank region, and later it may radiate or it may uh, changes its position from flank or loin region to groin region. So obviously the patient will eventually comes to you and saying that, sir, I am having severe spasmodic pain typically in the flank region, and after taking some amount of the water, and that now that pain has been somewhere mobilized in the groin region. Okay, so this is the typical presentation regarding the pain. Now you have to understand, apart from the pain, obviously there is a evidence of hematuria. Now this hematuria eventually comes from where? Now, as the stone that basically grazes through the urinary tract, there is a possibility of some amount of the bleeding, and that will eventually seen as a case of hematuria, and obviously the typical X-ray findings. So as you can note it, your calcium stones are the one of the most common stones that has been seen in as a urinary stone, like the calcium monohydrate, dihydrate, oxalate stone. Now these stones, obviously, as the calcium content is there, so they are easily able to seen on the X-ray. Mostly, not all, right? Not all kind of stones are seen in the X-ray, but most of them commonly they are seen. So obviously there is an image that has been given in here, so you can able to get the idea. Like in the X-ray, they are typically seen like this. So there is a visible multiple calcification. Okay, so this is how your renal calculi typically presents. Now your most common type, as I have already mentioned, this is your calcium oxalate stone. That is your most common type of stone that is there. Apart from that, you can also have uric acid stone. Like this kind of stone, they typically happen in case of high urine intake patient, or there is a patient of gout, they typically present with such cases. Also, we have the struvite stones. These are the special mention regarding these stones are basically needed. Why? Because in a patient with a subsequent urinary tract infection, there is some organism, they basically produced urease, uh, and that will eventually leads to the formation of the struvite stone. Okay, and this kind of patient, they will eventually presented with recurrent episodes of urinary stone. So that's why they are basically taken under the consideration. Now what are the risk factor? Obviously your dehydration, right? Dehydration is there, hypercalcemia, and any causes of the hypercalcemia, and among them obviously your hyperparathyroidism also falls under that scenario, and certain metabolic condition is also there. Okay, so obviously, as you can easily able to understand, the clinical scenario that has been given in this question eventually suggesting us towards the renal calculi. Now let's check the other option. So we have the parathyroid adenoma. Obviously your parathyroid adenoma eventually associated with a increased level of the calcium in the blood, and that is eventually seen in the urine as well. Like there is a hypercalciuria. Now this hypercalciuria eventually resulted in a formation of the stone as well. So stone eventually seen in case of parathyroid adenoma. Okay, but the problem is that In case of parathyroid adenoma, there is some adjacent feature is also will be mentioned in this question, which is not there. Like there is a features of fatigue, there is a features of muscle weakness, excessive level of the thrust. These are the typical features that will be seen in case of parathyroid adenoma, which is eventually absent in this question. Now, in a patient with polycystic kidney disease, these are the patient who eventually presented to you with a part abdomen lump that has been palpable, right? So this palpable lump, they're most of is cystic in nature, and obviously while doing a imaging, you can also able to get the confirmation regarding the cystic nature. They are not associated with a stone in such cases, and obviously the flank pain and that hematuria is eventually present in case of polycystic kidney disease, but not association of stones. Okay, not association of stones. Now, typical features. Now, obviously, you can easily able to understand the clinical scenario that has been given in this question, and here the presentation with the PCNL is eventually similar, except that X-ray. So your X-ray shows cyst, not calcification, right? And the CKD, there is a gradual loss of the kidney function. Obviously, there is a sometime coexistence of the primary cause as a coexistence of the primary cause as a multiple stone could be there, but in that case, there is a swelling, urinary changes and the fatigue that would be there. Okay. Now let's try to understand few important aspects regarding the urolithiasis. It has been one of the most important topic for your exam perspective. Multiple times they have asked multiple questions in the examination, so you have to learn it properly, right? First of all, regarding the urolithiasis, we have the risk factor. Regarding the risk factor, there is a two kind of risk factor. One is a modifiable and the another is the non-modifiable. In case of non-modifiable risk factor, obviously your male sex has been seen with a much more incidence of the urinary stone than that of the female. But in case of male, it's a basically 4 to 6 decade where the patient comes more often. But in case of female, it's always a bimodal peak. Now, regarding the bimodal peak, one peak typically seen at around the third decade, another is around the post-menopausal period. So, that is basically the difference in here. Now, the higher risk has been seen with the typically white races. So, these are the non-modifiable risk factor. Now, regarding the modifiable risk factor, first of all, you have to understand there is a people who basically lives in the tropical region. So, there is a much more perspiratory loss. As a result of that, there is a lots of dehydration that has been seen. That makes the patient much more susceptible to develop urinary stones. Also, few drugs like the chemotherapeutic agent or the steroids, these are also like increase the chances of patient developing such stone. Okay. Now, after the discussion of the modifiable and the non-modifiable risk factor, let's try to understand few things regarding the pathogenesis of the urolithiasis. So, regarding the pathogenesis of the urolithiasis, first of all, you have to understand there is a most important culprit salts for the development of the stone is that there is a calcium and there is a oxalate stone. Also, we have some inhibitory factors like there is a pH, there is a Tom's Horsfall mucoprotein that has been seen that also inhibit the formation of the urinary stones. There is a citrate, potassium, magnesiums. These are the one which inhibits the formation of urinary stones in the urine, right? Now, sometimes this culprit salts basically increases in the amount of the inhibitory factor. So, as a result of that, there is a formation of crystal. Now, this crystal you can see in this image, right? So, these are the typical shapes of the multiple crystals that has been seen with the urinary stones. Now, your exam perspective, this is the very important topic. Like there is a multiple times only question that has been asked regarding the image of this crystal. Okay, so you have to learn it properly. So your number one important thing is the calcium oxalate monohydrate crystal. Now, this calcium oxalate monohydrate crystals, they are typically seen as a shape of dumbbell shape. You can easily able to appreciate that, right? Also, you have the calcium oxalate dihydrate, which is typically seen as a envelope shape, right? Envelope shape. Also, your uric acid stone that has been seen as a rosette shape or multifaceted shaped. And we have the amorphous uh, shaped calcium phosphate and the bruchite stone, which is typically seen as a needle shaped. And the staghorn, they are typically forming a crystal that looks similar to the lead shape coffin lid shape. And the cystine stone, these are the hexagonal in nature. So this crystal, how they look, this is your important uh, aspect of your question. Now let's come back to the pathogenesis. So we have the crystals. Now these crystals, they are basically anchored in the renal papilla. Now this whole thing is basically known as the Randall's plaque. Randall's plaque. Now as a result of that, there is a changes of the pH and there is a subsequently formation of the urinary stone. Like your acidic pH basically precipitates the formation of uric acid stone, while your alkaline pH basically precipitates the formation of the calcium phosphate stone. Okay, so there is a difference of pH. Different pH basically precipitate different type of stones in that case. Now you have to, another important aspect of the pathogenesis is the stasis of the urine. So as a result of stasis of the urine, there is a precipitation of this crystal has been seen throughout the ureter. So as a result of that, there is a multiple small calculi has been seen on the ureter with a smooth surface, and they are typically known as the milk of stone. Milk of calcium stone has been known as. Now let's try to understand what are the type of stone that has been available, right? So your type of stone, number one is the calcium oxalate stone. So your calcium oxalate is the one of the most common stone that has been seen, but the predisposing factor, obviously your hypercalciuria is the one of the most important. Apart from that, your hypercalcemia, that is also there. Now your hyperoxaluria means increased amount of the oxalic acid in the urine, increased amount of the uric acid in the urine, and the hypocitraturia. These are the typical factor that has been responsible for formation of the calcium oxalate stone. Also, we have the primary hyperparathyroidism, because as a result of primary hyperparathyroidism, there is increased production of the PTH hormone, right? Now, this PTH hormone eventually goes into the bone and into the uh, it basically eventually goes into the bone, and there is an increased bone turnover. As a result of that, there is an increased amount of the calcium in the blood, but also it will increase the production of the 125 dihydroxy vitamin D3. Now this increased synthesis of the vitamin D3, these are often associated with the increased calcium absorption through the gut and from the kidney as well. So now as a result of that, there is an increased amount of the calcium has been seen. Now this increased calcium eventually replicated into the increased amount of the calcium in the urine. As a result of that, there is a formation of stone. Now you have to understand how this hyperuricosuriasia is associated with a calcium oxalate stone. Now let's try to understand, when there is a formation of the uric acid crystal, it can go in two ways. Like it can form the uric acid stone, or you can form into the calcium oxalate stone. It can forms both type of stone depending upon the pH. This is what is basically important. In case of acidic environment, there is a aggregates of the calcium oxalate on this crystal. So there is a formation of the calcium oxalate stone. Now your calcium phosphate, these are the rare one. We have the apatite and the bruchite stones. Now your apatite are the infection, like the infective pathology, where you can able to see the apatite stone, but you have the bruchites, which has been seen with the distal RTA. Okay. Regarding the uric acid stone, I have already mentioned there is an increased uric acid in the urine. So that has been seen with the myeloproliferative disease and some amount of the gout. And here, like I have mentioned, like the uric acid crystal, it can go into the both ways. Like as we have seen, in case of acidic urine, it will form the calcium oxalate stone. In case of alkaline urine, it will form the uric acid stone. Okay. Now, regarding the other types, like there is a infective stones. So already we have the appetite stone, then comes your struvite stone. Now, why this kind of stone has been formed in presence of infection? Because there is some organisms are there. So they are the protease. So we have some organisms are there, like they are the urease producing bacteria. Like there is a Proteus, Klebsiella, Serratia, Enterobacter. So they eventually associated with a urea hydrolysis. As a result of that, there is a alkalinization of the urine and also formation of the ammonia and the carbon dioxide. Now this alkalinization associated with a much more chances of stone formation. So apart from your appetite stone, we have the struvite stone. Now let's try to understand few things regarding the struvite stone. So the struvite stones are the one, these stones basically grows through the pelvic calyceal system. So as a result of that, there is a typical branching kind of shape it takes. So this is the basic peculiarity of the struvite stone. Now this kind of stone eventually presented with obstructive uropathy, and subsequently there is a loss of renal function associated with some chronic infection as well. Recurrence is pretty much common in such cases, so that's why complete clearance is very much necessary, because the persistence of bacteria is associated with this recurrence. Your long-term chemoprophylaxis is sometimes mandatory in such cases, just to remove that needles of infection in that case. Now we have the cystine stone. These are the strongest stone, which is basically pretty much hard to break through the ESWL. But these are the one associated with the autosomal recessive inherited disease. And that typically happens due to decreased reabsorption of the cystine from the intestine and the PCT as well. Okay. Now, these are the one which basically insoluble even at physiological pH and worsen with increasing activity. Okay. Now, what are the complication? Okay. What are the complication of the urolithiasis? That is your bilateral obstructing ureteric stone, right? Bilateral obstructing ureteric stone. So this obstruction eventually presented with a bilateral hydronephrosis. There is obstructive uropathy that has been known. Apart from that, there is some infective sequelae that can also be seen. Now, as there is a formation of the bilateral hydronephrosis, there is a some amount of the pressure basically goes into the kidney, and there is a eventually decrease amount of the urinary output, and eventually the anuria can also be seen. Among the infective pathology, obviously we have the pyelonephritis, pyelonephrosis. Eventually it can proceed into renal abscess or septicemia in that case. Okay. Now, pretty much uncommon, but it can happen, that is your cutaneous fistula in neglected cases. It's pretty much uncommon, but obviously there is some serious consequences of the complication of the urolithiasis, is that there is a formation of cutaneous fistula, that too in case of neglected cases. Okay. And in case of long standing cases, the patient can present it to you with a chronic renal failure as a result of both obstruction and infection. Okay. Now, what are the investigation we would like to go for in such scenarios? Obviously, your urinary examination. In the urinary examination, we try to look for whether there is any evidence of the hematuria, any evidence of infection. That's it. Also, your uh, complete blood count is there. So regarding the complete blood count, we try to look for the evidence of the infection here as well, like the increased leukocyte count suggesting towards the like we have to proceed with some amount of some antibiotics in that patient. Okay. Also, always try to rule out the pregnancy fast. Okay, in case of female patient, obviously, because some scenarios I have seen in my life, like this kind of similar features, like the differential diagnosis in case of right sided pain also comes as a appendicitis. And in that case, I also like to go for the pregnancy test first. Always rule out, because uh, there is evidence we have opened the abdomen and we are able to found some ectopic pregnancy in such cases. Okay, so you have to be pretty much cautious. Now your ultrasound basically going to be your first line of investigation. So it's a pretty much good first line test. It will eventually rule out lots of the other differential diagnosis. Your non-contrast CT is the investigation of choice. Why? Because it will allow you to diagnose both radiopaque and radiolucent stone, except of indenervated stone. Okay, so this could be your potential MCQ for your examination. Okay, now some patient with further complication that can also be seen in case of CT scan. Okay, so in that case, obviously your emergency treatment is necessary. Otherwise, if there is a without infection, in that cases you can go for the conservative management followed by selective removal of the stones. Regarding the metabolic evaluation, obviously there is a some instances will come while seeing such patient, like some patient will come to you and you offered your possible treatment. The patient basically goes with a smile with a complete cure, and after few months the patient come back and are telling you that, sir, I am having the same problem again and again. So there is a multiple episodes and the recurrence. In that case, you have to go for the metabolic evaluation. So what are the metabolic things we have seen? Like the increased calcium, there is a hyperparathyroidism, or there is a some amount of the hyper uh, uricosuria, or the gout, or the some myeloproliferative diseases there or not. These are the things you have to go for, you have to look for. So calcium, phosphate, uric acid, these are the three basic thing you would like to go for serum biochemistry. Okay, uh, now let's try to understand regarding the basic treatment. So we have the non-surgical management, which is basically watchful waiting. So who are the patient of this watchful waiting? So we have a patient with a small stone, like small means how much small? It is your less than 5 millimeter. Or the patient comes to you with no symptoms at all. So some sometime this kind of patient comes to you with a like they are pretty much worried about their health. They basically do uh, regular interval ultrasound on their own, and in some ultrasound they are able to find like there is a stone, but there is a no symptom at all. In that case also you can go for the waitful watching, and there is a non-complicated stone. It's a rather than non-obstructive. Okay, non-obstructive or the non-complicated stone, no infection, no pyelonephritis, no obstruction. In that case, you can go for that as well. Or the location of the stone is somewhere in the lower pole of the kidney. So this kind of stone eventually goes on its own, and the preserve renal function, where you can easily pose the patient for follow-up. Okay. Now, how would you like to go during this watchful waiting period? So we have the medical expulsion therapy. So in that case, we eventually go with the tamsulosin, which is basically alpha 1 blocker. Now this alpha 1 blocker tamsulosin eventually smooth muscle relaxation, typically at the distal end of the ureters, which is basically eventually increases the chances of the passage of stone through the urinary tract, and it will eventually get evaporated through urine only. And we ask the patient to take lots and lots of fluid and this tamsulosin, and sometimes deflazacort also combined with a tamsulosin. The function is pretty much same, and they are typically given at the bedtime, because there is a increased chances of the postural hypotension, so that can be that chances can be decreased by giving it at the bedtime. Now another important utilization of this medical expulsion therapy is that while after your ESWL, we basically try to do for the stone expulsion, like the stone fragmentation followed by expulsion. Now while doing the expulsion, if we are dealing with a stone that is more than 5 millimeter, this expulsion therapy is pretty much useful for the evacuation of all the stone fragment. Okay. Now let's try to understand a few important thing about the extracorporeal shockwave lithotripsy. Now this is basically a non-invasive test. This is the your office-based uh, uh, um, treatment method that you can easily adopt. So what it basically does, it basically locates the stone first, either through ultrasound or through fluoroscopy, followed by targeted acoustic pulse. that basically generated and focused on that particular stone. So as a result of that, it basically goes into multiple fragmentation as a result of energy transmission. And now this fragmented stone can be easily evacuated through the urinary tract. Okay. Now, few important thing is that it eventually decreases the efficacy of the ESWL with increased number of stones and the volume of the stone burden. Okay, so that you have to understand, like the increased number of stone and the increased size of the stone eventually decreases its efficacy. So there is a one term that is known as the Steinstraße, which is basically in German word. The meaning of this is the street of stones. Now it basically describes there is a closely gathered stone fragments are basically there in the ureter. Okay, this typically is seen when there is a stone burden is much more, and you have done or you have sent the patient for the ESWL, and following that you have received in such scenario. Now the chances is that there is a much more chances of the obstruction, and this will eventually require some urgent surgical intervention in that case. Now your clinically insignificant remnant fragments which are eventually there, if they're less than 4 centimeter, they are the one eventually pass spontaneously. But if the size is more than that, more than 5 millimeters, so it will be the troublesome thing in that case. Okay. Because this more than 5 millimeter stone fragments, they are eventually forming the nidus for another stone formation, and there is a recurrence from that. Now let's try to understand regarding the surgical management from here. Okay, so regarding the surgical management, first of all you have to understand what are the indication. Obviously your failed medical management, impaired renal function, there is a complicated one, sometimes there is a staghorn calculi, or there is a high risk occupation like they are the pilots, long distance locomotive drivers, sailors, or sometimes the patient comes to you and asking for surgical management. So obviously what are the options we have? So we have the ureteroscope. Okay, so regarding the ureteroscope, there is a long thin scopes are there that eventually used to remove the uretary stones and the renal stones in that case. So it could be a flexible or a semi-rigid in that case, and through that ureteroscope there is a few separate channels through which we can introduce the energy source, graspers and the basket as well. Okay, your ureteric avulsion, it's a potential risk in that case, so that's why you have to be pretty much careful while using the basket under the vision. Okay, sometimes it may complicate in patient with the bleeding disorder. So these are the one which is the contraindication in ureteroscope. So if the patient is having some amount of the bleeding disorder, it's a contraindication. Now your RIRS, retrograde intrarenal surgery. So basically slimmer cystoscope that has been introduced through the ureteric orifice, and the basic advantage is that the tip of this probe that basically have a active deflection, so it's basically less traumatic, and you can also introduce the laser with it, which will eventually helps you for stone fragmentation in that case. Okay, so it's a basically retrograde access to the kidney through the ureteric orifice, and the laser can be used as an energy source. So the indication, obviously renal stone that is less than 2 centimeter, right? Your lower pole calculi and the obesity. Okay, obesity, and sometimes the musculoskeletal deformities like the kyphoscoliosis, renal abnormalities are also one of the important. But the good thing is that your bleeding disorder, which are eventually contraindicated in case of ureteroscope, you can use it here. Then there is a PCNL. So the PCNL is basically there is a creation of the tract. Now this tract has been formed, or created through the skin into the renal pelvis directly. Okay. Now, for that case, we eventually used a larger kind of French, larger French for the dilatation. But obviously, we have the further modification, which is known as the mini park. In that case, the diameter of the tract is pretty much low. Now, these are the procedure which eventually done in this prone position, and before doing the procedure, we have to locate the stone. What is the exact location, and through uh, by that information, that will eventually guide us for the tract formation. Okay. So this localization can be done with fluoroscope or ultrasound. Your posterolateral calyx, your posterolateral calyx is supposed to be the entry point of such cases. So this two important, let's say the three important points are the one that has been asked in your question previously. Okay. Now, you can also go for the laser lithotripsy or sometime pneumatic lithotripsy. The complication is basically your bleeding. Okay. Bleeding is going to be the pretty much complication. Sometimes infection can happen, and the pleural violation resulted in a pneumothorax in such cases has been also seen in case of specifically supracostal puncture. Okay. But your severe bleeding sometimes may require angioembolization in that case. Now, the indications are obviously more than 2 centimeter stone. It's a lower pole renal stones with anatomy that has been not that much favorable with the other procedures. Your failed ESWL or the RIRS for the renal calculi is also going to be the another important indication. And last but not the least, your staghorn calculi. Only treatment for the staghorn calculi you can offer is that PCNL. Contraindication, obviously, your pregnancy and your untreated UTI. Untreated UTI, eventually there is a formation of the fistula. Uh, the chances is pretty much high. And the bleeding diathesis and the current anticoagulation that will eventually result in a profuse bleeding in such cases. We have the miniaturized PCNL, which is also known as the mini park. It's a smaller access track has been done. While doing the, as I have already mentioned, in case of PCNL, it's a 28 French tract, while in case of mini park, we have the 22 French tract, right? So it's typically done for the smaller stone burden and in case of children in that case. Okay. Now, your non-endourological surgical management, obviously, you have the open surgery, such as complicated case like the pyelolithotomy, or there is a anatrophic nephrolithotomy is reserved for the complex and infected stones with anatomical abnormalities in that case. So, simply for the prevention, you always ask your patient to drink much more amount of the fluid, like it's around 2.5 liters per day. Your daily dietary calcium supplementation should not be stopped. Yes, I am repeating it that it should not be stopped. Okay, it should not be stopped. Supplemental calcium as well, if necessary, should be taken at meal time. But obviously, over overuse is not good at any condition. But if the patient is basically required that, it should not be stopped. And reduce the intake of animal protein and the salt. So these are the basic three advices you would like to give your patient in that case. Okay. So we are discussing this MCQ like a patient experiencing flank pain and the hematuria. There is a X-ray reveal presence of multiple calculi or the calcification of stone in the both kidneys. Most probable diagnosis obviously renal calculi, because the features flank pain hematuria is there and the X-ray features is also there. Okay.